basically differentiate mild, moderate, and severe PPHN. How we categorize the mild, moderate, and severe PPHN, and what all indices we use. In literature, the indices are many. There are many indices, advanced indices also. For the basic ones, we use few indices to basically differentiate mild, moderate, and severe PPHN with those indices. So, Dr. Tushar, over to you. And I would request Dr. Tushar to keep it in the basic indices because the group is for the basic workshop. So, we will discuss the basic indices for the PPHN. Dr. Tushar.
Thank you so much, Dr. Mohit. Thank you, Rajesh sir. Thank you, IAP Bhubaneswar, for this opportunity, and welcome you all. So I will be talking on pulmonary hypertension, and keeping in theme of the workshop, that is basic aspects. And as we begin, what we need to remember is what exactly is pulmonary hypertension. So why the pulmonary hypertension issue is important in newborn period? Because beyond newborn period, we say that the pulmonary artery pressure is age independent. So which is about 15 millimeters of mercury. Okay. And if the mean pulmonary pressure is about 25, then we consider it as a pulmonary hypertension in a period above 1 month of age. But when we talk about newborn period, we have to remember that in the newborn period, the exact value of pulmonary hypertension is not clear because it is gestation age dependent. And when the baby is in utero, the pulmonary pressure is high. And after the baby is born, over a period of first few weeks, the pulmonary pressure is expected to drop to the adult level. So adult level, which is less than 15, less than 15 millimeters of mercury. Okay. So how do we diagnose pulmonary hypertension? Ideally, it is gold standard is cardiac catheterization. And criteria to diagnose pulmonary hypertension is mean peak pulmonary artery greater than or equal to 25 millimeters of mercury, and pulmonary vascular resistance greater than 3 unit per meter seconds, and pulmonary capillary wedge pressure less than or equal to 15 millimeters of mercury. But again, this is a gold standard which we are unable to do in newborn period, and therefore what we have to rely upon is the echo parameters. And so what is the role of echo in a baby with suspected PPHN? Basically, to diagnose pulmonary hypertension, to exclude congenital heart disease, quantify the pulmonary pressure, and assess the biventricular function, more specifically right ventricular function, and monitor response to therapy. Now, these are the aspects what we are going to deal today with point of care echo of a baby with suspected pulmonary hypertension. So I would like to keep it very simple. Normally, when we assess the pulmonary artery pressure, we go by these three methods, which is the peak velocity of tricuspid regurgitation jet. I will show all this. And then second method is assessment of PDA shunt if the PDA is open, and acceleration time in main pulmonary artery. So these are the three parameters that we commonly use to assess pulmonary hypertension in the newborn. But as Dr. Mohit said, there are many other parameters that we come across and they have been described. But other important signs, I would say, size of RA, RV, assessment of interatrial shunt, geometry of interventricular septum, left ventricular eccentricity index, pulmonary regurgitation, and paradoxical septal movement. So all these are corroborative as well as some other important findings that we need to look for when we talk about pulmonary hypertension. So let's go because it's a workshop and not a lecture. What we will like to see is how to get to these basic indices or basic parameters. So the first one, the commonly used one, is the tricuspid regurgitation jet. So what happens when the pulmonary pressures are high? That leads to dilatation of the right atrium, right ventricle, and so tricuspid wall ring gets dilated, and which each systole, a jet of blood leaks from right ventricle into the right atrium, and the velocity of TR jet is measured. We apply Bernoulli equation, which is equal to 4 into velocity square is the pressure gradient between the two chambers. So what we do is that we put the probe in the apical 4-chamber view with the orientation marker towards around 3 o'clock, and the angle or direction of the probe is towards the right shoulder, that is towards the long axis of the heart. And we get the apical 4-chamber view. We identify the chambers, we identify the walls. I'm sure this is covered How do we identify the tricuspid valve? The valve which is more apically placed is the tricuspid valve, and that is the golden rule. So, one second, I'll get the laser pointer. So if you look, what we have to do is we have to get a apical four chamber view, and we have to focus here. Here the valve which is more apically towards the apex is the tricuspid valve, and the valve which is little distant or away from the apex is the mitral valve. So we focus on the tricuspid valve. We look at the tricuspid regurgitation jet. So once you put the color Doppler in that area, you will find a regurgitant jet which is away from the probe, which gives you blue color. And then we put the continuous wave Doppler, because generally the velocities which are regurgitant, they are about 2 meter per second. If you use pulse wave Doppler, you will get aliasing effect, and you will not be able to measure velocities which are more than 2 meter per second. So put the continuous wave Doppler in alignment with the jet of the tricuspid regurgitation, and put the continuous wave Doppler and press the button. And what you get is a regurgitant jet like this. Okay, so this is the regurgitant jet from the tricuspid valve, and try and get a complete envelope. Now this is the skill, and this will happen with practice. Many times you will get some regurgitant jet, but you will not get a complete envelope. So this is called envelope. This portion is called envelope. Okay, so if you're not getting complete envelope, you have to kind of manipulate the probe. You have to do the art of image optimization. So whatever the probe is there, you have to kind of align with the long axis, rotate the probe, tilt the probe, so that you get a proper, better ejection waveform, and measure the highest measured velocity. So suppose here you are getting, so here I am happy that this envelope is come complete here, and then I am measuring the velocity here from the baseline, and the baseline velocity comes around 4. Baseline velocity is nearly almost 4, or it is shown here 3.85 meter per second. So the regurgitant jet velocity is 3.85 meter per second, and the machine itself calculates with Bernoulli equation, which is 4 into velocity square, and that gives you gradient of 59.2 millimeters per mercury. So the gradient across tricuspid valve in this case is about 59.2 millimeters of mercury. So I hope this is clear. So this is the most common method that we use commonly, and this is we're going to use later on also. Now, can anybody, so what you do is that you do apical four chamber view. This is little subcostal, apical view is not coming properly. So this is little suboptimal, but I am getting a good pulmonary, good tricuspid valve opening. I put a probe there, and then I get regurgitant jet, blue colored jet, which is seen at tricuspid valve. And then I put a continuous wave Doppler there, and I get a regurgitant jet. And here I can get the velocity, and based on that, I can gradient of 56.2 millimeters of mercury. So this is the graphic depiction of Bernoulli equation, that tricuspid regurgitation velocity is important in order to put into this equation, and this will give estimated right ventricular systolic pressure. So this estimated so this is the gradient of 56 is the gradient across the tricuspid valve. Now when you want to find out what is the pressure in the right ventricle, then we have to add this pressure of right atrium. So 56 is the gradient. So if I want to know what is the right ventricular peak systolic pressure, I have to add the right atrial pressure, which is about 5 to 10 millimeter of mercury. So in that equation, I will get 56 plus 5, which is about 61 millimeter of mercury. So my estimated right ventricular peak systolic pressure is 61 millimeters of mercury. Now the question comes whether this, when we want to calculate the right ventricular peak systolic pressure, does this pressure remain same for a preterm baby, for a 26-weeker, for a 28-weeker, or for a 40-weeker or 39-weeker? So therefore, the problem comes into picture whether when to call it is a pulmonary hypertension. So suppose you have an extreme preterm baby, you cannot have, so one single value will not tell whether there is pulmonary hypertension. So there are different criteria. So now what we use is right ventricular systolic pressure. If it is more than 40 millimeters of mercury, we consider it as a moderate pulmonary hypertension. Or for a preterm baby, small baby, what you can take is a systolic blood pressure. So divide it by 2. So your systolic blood pressure is suppose 45 or say 46. So divide by 2. If the ratio is say more than 23, we will consider it as a significant. So right ventricular systolic pressure divided by systemic systolic blood pressure. If it is more than 1:2, then we consider it as a pulmonary arterial hypertension. So to make it easy, suppose you have a 30 weeker and you are getting a tricuspid regurgitant jet, and then you estimated the right ventricular peak systolic pressure around 35, and you are getting a systolic blood pressure of 45, then this one is significant pulmonary hypertension. So how to grade the severity? Now again, the problem comes, so suppose if you are dealing with a full-term baby, so right ventricular systolic pressure, which is between 25 to 40 is a mild, 40 to 60 is moderate, and more than 60 is a severe. Or if you look at the gradient wise, if it is subsystemic, it is mild. If it is equal to systemic, it is moderate. And if it is a suprasystemic, it is a severe pulmonary hypertension. So there are different methods of grading pulmonary hypertension. Similarly, grading based on the ratio of right ventricular peak systolic pressure divided by systemic blood pressure. Now this is something which I find useful even for preterm babies. So suppose if the ratio is more than 1, it means that it is a pressure is suprasystemic, and that is a severe pulmonary hypertension. If the ratio is between 50 to 67%, then it is a moderate pulmonary hypertension, and none or minimum when the ratio is kind of less than 50% of systolic systemic blood pressure. All right. Simplified version: mild less than 40, moderate 40 to 60, and severe is more than 60 millimeters of mercury. So this will apply mainly for full-term babies, but when you're talking about preterm babies, we have to follow this. A few years ago, we used to believe that preterm babies do not have pulmonary hypertension. Preterm babies cannot, but now it is proven without doubt that preterm babies also can mount significant pulmonary hypertension, and they may require therapies which we are using for full-term babies: milrinone, sildenafil, nitric oxide, so on and so forth. And this applies more so in a preterm baby which is growing and developing bronchopulmonary dysplasia. So initial transitional circulation also sometimes they can have pulmonary hypertension, and these babies can have later on pulmonary hypertension during the phase of bronchopulmonary dysplasia. So again, one more example here, I am showing the same. You do a continuous wave Doppler at the site of tricuspid valve, try and get a good complete envelope, measure the difference or pressure velocity of the tricuspid jet, which is showing here as 374 centimeter per second. The pressure gradient machine is giving to you is 56, which you can manually calculate by 4 into velocity square. So 4 multiplied by 3.74 multiplied by 3.74, because you take velocity in meter per second, and what you get is 56.2. So this is the gradient, and therefore estimated right ventricular systolic pressure is 61 millimeters of mercury. And I am putting more emphasis here on this because most of you will be relying on this tricuspid regurgitation jet, because this is the commonest used method, and this is more reliable, and inter-observer variability is very less. Also, you can observe progress of the patient over a period of days once you start therapy to reduce pulmonary hypertension. Now, sometimes you are unable to get a good view at the apical 4-chamber view, and therefore one can also do this same tricuspid regurgitate assessment by parasternal long axis view. So for parasternal long axis view, you use a ultrasound probe, put it in the lower parasternal area with the orientation marker towards 10 to 11 o'clock. That is the long axis of the heart, and you will get images like this. The central image is the midline image, where you are able to see left ventricular outflow tract. So this is LA, LV and LVOT. And once you do a medial sweep, so you have put it here on the chest and you do the medial sweep. Once you do the medial sweep, you will be able to see this particular image, where this is the right atrium, tricuspid valve, and this is the right ventricle. And you will be able to assess pulmonary hypertension in this particular image. If you are doing lateral sweep, you will be able to see crossing of the great vessels. And this particular view is important to rule out TGA. So we'll not talk about this. We'll talk about this particular view, wherein long axis medial sweep. So what you do is that you get image like this: right atrium, right ventricle, tricuspid valve. You put the color Doppler, you will see red velocity, which is basically atria opening into the right ventricle, and which is towards the probe. So you get a red colored jet here. But when there is a tricuspid regurgitation, you will get velocity like this. Again, the same principle will apply. Calculate the TR max, which is 3.4, and calculate the gradient, which is 47. And then the pulmonary artery pressure, that is what we talk about, is basically right ventricular peak systolic pressure or pulmonary artery pressure, which is about 52.4. And here I have put the calculation. Okay. So this is for ease and simplicity for everybody to understand. I hope this is clear. I've given enough examples here. Now let's move on to the second method of assessment of pulmonary artery pressure, and that is through ductal shunt. So the blood flow across PDA depends upon relative pressure gradient between aorta and pulmonary artery. Now here we have to remember that the PDA has to be non-restrictive. The PDA has to be wide PDA. If there is a narrow or constricted PDA, this will not give you a good pressure. This will not give accurate pressure gradient across the PDA. So what you do is that measure the velocity of jet. The systolic pressure gradient between the pulmonary artery and the descending aorta can be measured. And pulmonary artery pressure can be derived by adding or subtracting the pressure gradient from aortic pressure. So I'll explain it here. So what you do is that you try and get a ductal view. As you can see here, this is the ductal view. This is like a tripod appearance, but the right pulmonary artery is not seen properly. This is the left pulmonary artery. This is the PDA. You put the color there and you see the PDA jet, which is coming from left to right. So you put the color continuous wave Doppler there and you will get a velocity. So either the velocity will be below the baseline if it is a right to left shunt, velocity will be above the baseline if it is a left to right shunt. Now in this case it is a left to right shunt, and therefore what you can see is a pure left to right shunt. So here you are able to measure this velocity. So here the velocity is 1 point, you measure it here at the maximum velocity, which is about 1.29 meter per second. Therefore the pressure gradient across the PDA is 4 into velocity square, which is about 5.8 millimeters of mercury. And since this is a pure left to right shunt, the pulmonary pressure is lower than the systemic pressure, and therefore the systolic pressure in the arteries is 40. So you subtract 5.8 and what pressure you get is 34.2. So your pulmonary artery pressure is 34.2. Now when I say this, again we have to remember, if the PDA is constricted, then this pressure gradient you may not get accurate. So there is a fallacy here. So if the PDA is constricted, you may get a you may not get accurate reading here. Now similarly, if the velocity is right to left, so there is a mistake here. The velocity is right to left from main pulmonary artery into the descending aorta. Then again you calculate the pressure gradient across the PDA below the baseline, and that coming as 2.7 meter per second. So you measure it at the PDA level, and this velocity is 2.7 as it is shown here. This is the measure. The highest velocity you calculate always. And that velocity is coming 2.7 meter per second. The pressure gradient is 29.3, and therefore the systolic, if the systolic blood pressure is 40, then the pulmonary systolic pressure is 40 plus 29.3, that is 69.3 millimeters mercury is the right ventricular or main and or pulmonary artery peak systolic pressure is 69. So I hope this is clear. So when you have a pure left to right shunt, subtract it from systolic blood pressure. When you have pure right to left shunt, add it to the systolic pressure to get the main pulmonary artery pressure. Now the problem comes when you have a bidirectional shunt. Now, please remember that when you have a bidirectional shunt, basically the pressure waveform from why there is a bidirectional shunt, because the pressure waveform from the right side arrives before that from the left side. Because normally, if you see the SA node is on the right side, the right heart contracts slightly earlier than the left side, and therefore the pressure waveform across the PDA, if you see, it comes little early on the right side in the main pulmonary artery as against the aorta. Therefore, if the duration of shunt across the PDA, if it is more than 30% of the times right to left, then we consider the pulmonary hypertension being significant. So I'll show you here by example. So now this is a PDA. So this is a Doppler across the PDA. Now, as you can see, this is the right to left shunt, which is below the baseline, and this above the baseline is left to right shunt. Okay. Now, what I do is that I calculate the duration of cardiac cycle, which is from this point, first negative deflection, to this negative deflection. So this is the cardiac cycle, and we measure the right to left shunt duration. So the right to left shunt duration divided by the duration of the entire cardiac cycle. So here, as you can see, right to left time is 82 milliseconds, and right to left to right is 463. That is a complete RR time. So a complete cardiac cycle time is 453. So right to left duration is 18%, and therefore this is a subsystemic pulmonary artery pressure. And therefore, so this is a subsystemic pulmonary artery pressure. So what you do here is that you calculate left to right shunt velocity, calculate the pressure gradient difference, and minus this difference from systolic blood pressure in the systemic arteries. So if your systolic blood pressure is 40, you will minus this kind of the whatever this reading comes around 5 or 6, you minus it, and that will give you right ventricular peak systolic pressure or main pulmonary artery pressure. Similarly, as you can see here, the right to left magnitude of the shunt is more than 30% of the cardiac cycle, which is about 38%. So here I will consider this shunt as a right to left shunt, predominantly right to left shunt, where the pulmonary artery pressure is expected or considered higher than systemic blood pressure. And therefore, we add the pressure into the systolic blood pressure to get the pulmonary artery blood pressure. So what I will do in this case is that I'll measure the velocity from baseline to this point, which is about 1.2 or something, and then 4 into 1.2 into 1.2 is the pressure gradient across the PDA, and that pressure gradient I'm going to add into my systemic blood pressure, which I'm going to measure by either invasive blood pressure or non-invasive, and then that will be your pulmonary artery peak systolic pressure or pulmonary arterial pressure. So I hope this is clear. So if it is clearly left to right shunt, you are going to minus from systolic blood pressure. If it is pure right to left shunt, you are going to add into the systolic blood pressure. And if it is a bidirectional shunt, you are going to measure the right to left component. And if the right to left component is less than 30% of the cardiac cycle, your pulmonary pressure is less than systolic pressure. And if the right to left component is more than 30% of the cardiac cycle, your pulmonary pressure is higher than systemic blood pressure. So this is the second method by which we estimate the pulmonary arterial pressure. Now moving on to the third parameter, which is a acceleration time in the main pulmonary artery. Now, as pulmonary artery pressure rises, the time to peak velocity, so TPV, this is a very important word, or acceleration time gets shorter. Now, I'll show you what it is. So, the acceleration time is confounded by the heart rate. So, to avoid that, ratio of time to peak velocity divided by right ventricular ejection time is taken. Normal ratio is more than 3. If it is less than 0.2, it is suggestive of pulmonary arterial hypertension. So, what we do is that concentrate on this image. This is the pulmonary artery view. How do we take pulmonary artery view? So, this is the ultrasound probe. We will place it in high parasternal view, high parasternal region with the orientation marker towards 3 o'clock. So that gives me pulmonary artery view. And or this can also be measured in the ductal view, where you get a long stretch of main pulmonary artery. Put the Doppler gauge in the center of the vessel, and what you get is a waveform like this. So this is the pulmonary artery ejection waveform. Now, so here, so have a concentration on this left side image. So this is the right ventricular ejection time, this entire duration, and we calculate time to peak from this point to, so where it peaks. So the consider this velocity ejection waveform of right ventricle, and time it reaches the peak velocity. So this is the peak velocity here, or here this is the peak velocity. So from this point to this point where it peaks, that is the time to peak velocity, that is we measure. So if you can see here, time to peak velocity is 57 milliseconds. So this particular part is 57 milliseconds as against the right ventricular ejection time, which is 164 milliseconds. And therefore TPV upon RVT as calculated is 0.34, which is more than 30%, which is a normal. Now look at this right-sided picture. Here, as you can see, there is a sharp pointed triangle, there is a notching, and then there is a waveform like this. So time to peak from the start of pulmonary ejection waveform till it peaks, and that time, as you can see here, is about 29 milliseconds, and right ventricular ejection time is 166 milliseconds, and therefore TPV upon RVT is 0.17, which is less than 0.2 or less than 20%, which indicates that there is a significant pulmonary hypertension. So the same baby where we had this pressure gradient of 61, pressure gradient of 56, and right ventricular peak systolic pressure of 61, the same pressures pulmonary artery waveform we have, ejection waveform, and as you can see there is a sharp pointed triangle with a notching. Okay, so here where we had calculated TPV upon RVT, that is less than 0.2. Okay, because you start from here, you measure it till here, and this particular section is entire right ventricular ejection time. So clear. So this is very important. So these are the three main methods that we follow, that we kind of use in our practice to decide whether the child has got pulmonary hypertension. There are advantages, disadvantages of each one of them. So if you look at tricuspid regurgitation method, it is repeatable, it is accurate, there is direct relationship, but we here assume the pressure in the right atrium, that the pressure will be somewhere around 5 to 10. What if the right atrial pressure itself is very high? So then you will get an erroneous reading. And the strong points is that it's accurate, repeatable, inter-observer variability is less. And one can say it is technically demanding, but with practice you will be able to do this. Second is ductal velocity. Now it is reasonable repeatability. There is inverse relationship between systolic, systolic pulmonary artery pressure. So the velocity reduces. So if the pressure is high, the velocity is less, and it is affected by systemic blood pressure and ductal constriction. So for this, you need to have systolic blood pressure in your hand, and you also need to make sure that there is no ductal constriction. It is easy to measure and needs patent duct. Now third, what we studied is TPV upon RVT, which has got poor repeatability. There is inverse relationship that the higher is the pressure, the lower is the ratio. And again, the studies have shown that it is not very predictable. It is predictable is less, and it is affected by RV function and easy to measure. And but the repeatability is little less. So again, keeping these things in mind, one can use these parameters in day-to-day practice. Sometimes you may not have tricuspid regurgitation, so use the other parameters to get to know the pressure. Also, we have to remember that when we measure tricuspid regurgitation, we look at right ventricular contractility. If the right ventricular contractility is less, the amount of blood or the force of blood which is getting ejected or getting across tricuspid valve is going to be less. So you may erroneously measure a low pulmonary artery pressure. So in such a patient, once you start them on inotrope, the right ventricle starts contracting nicely. but in the process you will get kind of higher tricuspid regurgitation velocity, and then you will measurement will say that after you starting therapy, the right ventricular pulmonary pressures have gone up, even though clinically baby is little better because the cardiac output has improved, cardiac contractility is improved. So again, we have to be careful that when you are measuring it with tricuspid regurgitation jet, one of the fallacy is that if the right ventricle is failing, you will get erroneously low TR jet. Also, if the right atrial pressures are high, the gradient may come less. So again, what I want to tell here is that none of these methods is foolproof. You have to rely on more than one kind of parameters. Now let's diverse a little bit. When we talk about these numbers, these parameters, these ratios, let's talk about obesity. Now, can anyone tell me what is obesity? I think is a direct communication is not there, but what is obesity? So suppose somebody has got body mass index more than 25, we'll call it as overweight. Somebody with more than 30 will call it obese, or abdominal circumference. If it is more than 2 in males or more than 88 in women, we will call it as obesity. Or ratio, if ratio is more than 0.9 in males, it is obese, and in the women, if it is more than 0.85, the waist hip ratio, then we'll call them as obese. Now, how many of you knew this, that this is the definition of obesity? But how many of you can tell me that this person is obese? How many of you want to know the abdominal circumference? How many of you want to know the waist to hip ratio? No, none of us, because this person is obese. The person has got gynecomastia. The person has got acanthosis nigricans. There is obvious overhanging fat belly. Also, you can see at the shoulder level, and there is obvious obesity. So one can tell that this person is obese. None of the ratios are kind of required. So you have to train your eye. What the point I want to make here is that as soon as you look at the heart, you start getting feeling, you understand that this person has got a pulmonary hypertension. So how many of you you can answer in the chat box? The left one is likely to have pulmonary hypertension, or the right one is likely to have pulmonary hypertension? You can type in the chat box. So one answer is there, right? Correct. So correct. So I think all of you are with me. So basically, right side, right, image, as you can see, the right atrium is dilated as against the left atrium. The right ventricle is dilated against the left ventricle. This view is is not very good. It should be at the apex, and this has gone little subcostal. But still, suppose you get a right ventricle which is bigger than the left ventricle. If you get right atrium bigger than the than the left atrium, then it is likely that the patient is going pulmonary. Please remember, no point in time in lifetime, right-sided chambers are bigger than the left-sided chambers. What happens is that at the time of birth and the transitional time, the right-sided chambers are equal to left-sided chambers, and over a period of time, right-sided chambers they regress. The right ventricle becomes very small. It becomes crescentic in shape. So again, just looking at this four-chamber view, I think that the baby Kumar right side, the one is having pulmonary hypertension. And you put a color there, and you get a TR jet. Okay. Now, so this is another method. So just looking at it. Now, another methods is basically interventricular septum assessment. Now, when you do a parasternal short axis view, you are putting the ultrasound probe in the lower parasternal area, and this is the long axis. You rotate it to 2 o'clock or 3 o'clock position, where the orientation marker is around 2 o'clock or 3 o'clock, and you get a parasternal short axis view. Now, what you get is that left ventricular cavity you get. These are the papillary muscle on both the side, and this is the central view, where there is this central is mitral wall, and this is the highest view, where there is a cup and saucer appearance. So this is LA, RA, RV, RVOT pulmonary wall, and this is the pulmonary artery, and this is the Mercedes-Benz sign, and this is the cup and saucer image. You go little down, you get the mitral valve, and you get little down, this is the papillary muscle level. Now, please remember that ventricular cavity should look like this. This is the interventricular septum. This part is the interventricular septum. And interventricular septum is designed in a way that it constricts or contracts as a part of left ventricle and not a right ventricle. So the left ventricle is expected to contract like this, and this is a spherical circular structure that you're seeing, and it is expected to contract like this. Now suppose you are seeing a ventricle which is D-shaped. So what has happened is right ventricular pressure has increased, and the ventricular interventricular septum, rather than being sphericals, it is becoming flat, and you are getting a D shape like this. So this D-shaped ventricle tells you that the right-sided pressures are very high, and this is just on the look of it. So when you have a D-shaped ventricle, it is kind of moderate pulmonary hypertension, where the right-sided pressure is equal to left-sided pressure. And when you have a crescentic, so sometimes what happens, this interventricular septum line is not flat, it becomes crescentic like this, crescentic. So it becomes crescentic, it means that it is a suprasystemic right-sided pressures. So in a mild pulmonary hypertension, you may have a circular left ventricular cavity. In a moderate pressure, you have a D shape, and in a severe pulmonary hypertension, you have a crescentic kind of left ventricular cavity. So this is a left ventricular cavity which becomes crescentic. Okay, so now is there any objective method of calculating this left ventricular shape? So there is something called as left ventricular end systolic eccentricity index. Now, if it is getting too complicated, I will just tell you to ignore this because this is one more index. But what the idea here is that at the end of systole in the left ventricle, the what you do is the measure length parallel to the interventricular septum versus length perpendicular to the interventricular septum, and divided to do so here S1 divided by S2, if the ratio is more than 1.3, it indicates that there is a significant pulmonary hypertension. Again, these are the newer studies, more applicable in adults. People have started using in the newborn and try to derive values. So these values they have derived in the neonatal population, Abraham et al. Again, these are something newer ones, but again, we are not using it so often. So this is LV end systolic eccentricity index. Now, again, the next point what you can look at is high parasternal pulmonary artery wave, which I said that you put it in the high parasternal area and rotate so that the orientation marker is around 3 o'clock. And what you see is that you see the main pulmonary artery and you will see the ejection pulmonary regurgitation. So what you can do, you can put the pulse wave Doppler across the wall and try and get the velocity of regurgitant jet. That will tell you if the right main pulmonary artery pressure also you can get like that. Also, we spoke about RVT upon TPT, right ventricular peak systolic velocity. So, this is right ventricular ejection waveform. So just looking at the shape of the waveform, as you can see, if it is a sharp pointed triangle like this, then this indicates sharp pointed triangle. This indicates that significant pulmonary hypertension is there. Normally, if the pulmonary hypertension is not there, you will see a tongue-shaped right ventricular ejection waveform. But when the pulmonary hypertension is there, just the look of it will tell you that it is a sharp pointed triangle, and that indicates significant pulmonary hypertension. So we are looking at easier other methods or things which can give you clue that there is an underlying pulmonary hypertension. Also, you can assess the interatrial septum by subcostal four-chamber view, and here you will be able to see the interatrial shunt. And again, you can put the pulse wave Doppler across the interatrial shunt, and what you get is a waveform like this. So this is a pattern of interatrial shunting. So normally, as I said, the right-sided chambers they contract little earlier than left-sided. So initially there is a negative deflection here, and then the remaining is a positive deflection of left to right shunting across the interatrial shunt. And so here, if the right to left deflection, if it is ratio is less than 0.3 of the entire cardiac cycle, that is normal. So if it is more than 40%, then it is suggestive of pulmonary hypertension. Now again, Don't go in details here because this will again confuse you, but there are methods of calculating pulmonary, identifying pulmonary arterial hypertension based on the shunting across intra-arterial shunt as well. So suppose you are getting, so the images will look like this. So right to left shunt component here. So this is the something which is below the baseline is right to left. So from this point to this point is below the baseline. So this thing, and the above baseline, that is left to right, is this component. So here the ratio comes around 0.5. So here you have to look for pulmonary hypertension, pulmonary stenosis. Suppose you are getting shunt like this. Everything is below baseline at the intra-arterial shunt level. Now why this intra-arterial shunting is important? Because if you are getting image like this, where there is a pure right to left shunt at intra-arterial level, then unless proven otherwise, this indicates one underlying congenital cyanotic heart disease. Can anybody tell which is the heart disease you look for when you get a Doppler like this at the intra-arterial shunt level? You can answer it in your chat box. So which heart disease you're looking at if you are getting a pure right to left shunt at intra-arterial level, and therefore it is important. Somebody has written tricuspid atresia, which is a wrong answer. Anybody else? Please answer those. So it is a TAPVC. Dr. Mahesh has answered it correctly. So basically, unless proven otherwise, so it is TAPVC. So you are getting a pure right to left shunt at intra-arterial septum level. So it indicates TAPVC unless proven otherwise. And the reason I am saying this is because in the TAPVC rest everything is normal. So the only source of blood for left atrium is through the intra-arterial shunt from the right side. Now somebody will say tricuspid atresia is also right answer, but tricuspid atresia has got many other things. For you to kind of, for the baby to survive, there has to have other kind of parameters, and the left atrium also is seen big there. So so unless proven otherwise, if you have pure right to left shunt at intra-arterial septum level, then it is TAPVC. One second. I don't know, it's not moving. So now this kind of tells us about right ventricular peak systolic pressure or pulmonary hypertension part. But again, we have to remember that along with pulmonary hypertension, there is most of the times there is right ventricular dysfunction. Dr. Mohit, I would like to know from you whether should I speak about right ventricular dysfunction about TAPC and fractional area change. So many of these babies, when there is a PPHN, there is right ventricular dysfunction is a part and parcel of this. So many of workshop we cover this right ventricular function in as a part of systolic function of the heart, where we assess right heart and left heart. But right heart is mainly affected when you have a PPHN scenario. So how do you decide right ventricular function? Based on the eyeballing or right ventricular fractional area change and TAPC. So just for you to know, so basically you take the right apical four chamber view and get a good view and kind of freeze the image. So you freeze the image and then take the image where the right ventricular end diastolic dimensions are highest and then end systolic dimensions which are the smallest. Okay, and measure this area. Will not go in technical aspect, but you measure this area of right ventricle at end of diastole and end of systole, and that tells you the fractional area change. Fractional area change is gestation dependent factor and it increases over a period of time. In case of babies above 36 weeks and in adults it is about 35%. So it should be above 35% in a full term baby. You have a meconium baby, you have asphyxia baby, full term baby. Measure right ventricular fractional area change, it should be above 35%. Now, and second component we do is a tricuspid annular plane systolic acceleration. So for right ventricular function is eyeballing. With eyeballing you see whether the right ventricle is contracting or not. Second component is right ventricular fractional area change, and third component is TAPSE, that is a tricuspid annular plane systolic excursion. So go for the apical four chamber view, M mode. So you go for the apical four chamber view. This is the M mode beam. The cursor should be placed at the annulus of the tricuspid wall, and when you press the button, the annulus with every beat moves towards the apex, because the heart on the right sided cardiac fibers, they keep they contract from apex to base. As against the left side of the heart, the fibers are circumferential, and as against the right ventricle, the fibers are from the annulus, that is the tricuspid wall annulus, towards the apex, and then they contract towards each other. And therefore one of the good methods of finding out whether the right ventricular contractility is good or not is TAPSE, that is tricuspid annular peak systolic excursion. So this beam goes to the annulus of the tricuspid wall, and when you press the button, you get a velocity like this. So this is the annulus which moves with time, and what we are interested is in calculating this excursion from baseline till the top. And this excursion in preterm babies is 4 to 6 millimeters, and in full term babies is 6 to 10, and in adults above 15. And suppose you are getting tricuspid TAPSE less than 6 in full term baby, or less than 4 or 5 in preterm babies, then the right ventricular function is poor. So one of the things, as I said, our objectives of our talk, we will go back again if you want. So those things we tried to cover. So summary is, PPHN is diagnosed on functional echo by assessment of TRZ, assessment of PDHN, or TPV upon RVT. Visual assessment of PPHN is done by looking at the chamber sizes, anatomy of ventricular septum. We can calculate eccentricity index there, shape of the pulmonary artery ejection waveform, and PFO shunt if the PFO shunt is present. And right side cardiac dysfunction is very common with PPHN, and we have to take care of that in order to assess the pulmonary hypertension properly. So this is all which I had to say. If there are any questions, I am happy to take the questions. Dr. Mohit, are we going to cover